And good morning still? Yes. We are broadcasting live from Duke Spine Institute and Surgery Center Vieira. This patient is here today because he's having back pain and leg problems. Pain down the leg. Sciatica from a herniated disc at L4-S1 and a herniated disc at L4-5. Shot? So first thing we're going to do is get into the L4-S1 disc and try to repair it. Let's go ahead and get an AP. We're going to use x-rays. These x-rays are front, back, and side to side. AP means front, back, anterior, posterior, and lateral is side to side. Looking good. So the first disc I always go after if I'm doing L4-S1, it's usually the bottom disc. That's the hardest disc to get to, and it's going to set the entry point for the surgery. Okay? In this case, we picked a good entry point the first time. Are you awake? Reliable or not? Num. Local.
Okay.
All right, let me know when he's awake and I can proceed. I'm going to, in the meantime, put the L4-5 needle. How come we have three?
I can use all.
Huh? Incision? Accidentally? Oh. All right. Those are expensive. I was just wondering if I was wrong about what we're doing here.
How are you doing, my friend?
All right.
How are you? Open your eyes for me. We have some questions for you.
All right.
Okay,
Let me know when you think he's fully awake and I can ask him some questions. All right. Well, so his spine is pretty far back towards his skin. Our patients that we see here, some of them the spine is closer to the surface here, others are way down. Shot. In his case, his spine is really close to the surface. Shot. So I'm passing the facets. I can feel the facets as I go past them, and I can actually feels like a herniation right here. Yep, at L4-5. Okay. And I felt the tear, by the way. So when you put a needle through the back of the disc, through the annulus fibrosus, if it's intact, if it's normal, there's a lot of resistance. But if there's a tear, you can actually push through the tear quite easily. There's definitely a tear there. All right, I'm going to wait for him to be a little more awake, and then I'm going to place the 5-1.
Open your eyes for me, my friend. Can you open your eyes? Good. Open your eyes.
Are you in pain?
Do you have any pain in your back, on your legs?
Now, how long has he had back pain for?
5 years, 2 months acute.
Lower back pain he's had for 5 years. He's not an old guy. And for the last 2 months, oh man, it's been bad. So he's been in severe pain for the last couple of months. But he's had back pain for 5 years. I asked him, where do you get your back pain? And this is what he showed me right here. He put his finger literally right around here and right around here. And what I saw on the MRI, this of course being L4-S1 and this being L4-5, these are the discs I'm talking about. I saw that the L4-S1 was really badly damaged with a big tear and a herniation. And the L4-5 had a smaller tear and a bulge, like a bulging disc, which we call it's a herniated disc, but we call it a disc bulge when it's small. All right, are you comfy?
Do you have any pain? Open your eyes for me. Good. Open your eyes for me. Good morning, my friend.
So he's lost like 2 drops of blood the whole surgery so far. This is a relatively bloodless surgery. The name of this surgery, for those who don't know, is called the Duke laser, because we use a laser. Disc, because we're operating on the disc. Repair, because we're helping to repair a disc. Okay? Duke laser disc repair. And today we're doing a left L4-5, L4-S1 on this patient, because I believe his back pain is coming from these 2 discs. based on his physical exam and his MRI. And I believe his leg pain is primarily coming from the L5-S1.
All right. Can you open your eyes? Try not to move your arms, okay? Keep your arms still. Can you open your eyes for me?
Can you talk to us?
Can you say hello?
Talk to us. So we're waking our patient up. He's been sleeping comfortably. I need him awake for this part. And then we're going to test those discs to see if they are indeed causing his back pain. We do that through what's called a discogram. Yep.
Can you open your eyes for me?
Shot.
Can you say it? Open your eyes. Can you say hello?
You having any pain?
Are you having any back pain? Any back pain, my friend? No? No back pain.
Any pain at all?
Any pain in your legs or anywhere? Any pain? No.
All right. I'll just give him another minute and then we'll proceed. And we're going to do the discogram using an injection of material that is really a combination of what's called omnipaque, which is a dye that we can see on the x-ray,
Open your eyes.
and
Any back pain?
also some blue dye that we use to stain the herniated disc. Don't move around so much, you're fine. Now, somebody asked me the other day, how do you make sure the patient doesn't move too much? Well, we want them cooperating. That's why we give them a drug that gives them clear thinking. But there's a period where they're just waking up that they're still moving a little bit, and he's going to get clear soon.
Can you open your eyes for me? Good. Can you open your eyes?
Don't move around.
Do you have any back pain or leg pain? Are you comfortable? Any back pain? No or yes? Huh? Gotta keep
So
your arms still.
he's still getting there. He's going to be there in a minute.
You gotta keep your arms still, okay?
Let's go ahead and get an AP while we're waiting.
You're in surgery, all right? Open your eyes for me.
Uh-huh.
You're just real sensitive. That's,
Oh yeah, that's fine.
open your eyes.
We find that a lot of patients are very pain sensitive. Just a little needle will actually set them off. All right, looking good. So look at the needle at L4-5. Show us the L4-5 needle, Jordan. I'm going to bring the arrow in and show you the L4-5 needle. It's in perfect position.
Can you open your eyes for us?
No, it's L5-S1. Show us
Are you having
L4-5.
any
Yeah.
back pain?
So L4-5 is in position. It's perfect.
Hey honey, are you having any pain?
Now we're going to finish placing the L5-S1, but I need him more awake. We're going to have him wake up. Stop moving around.
You gotta stop moving, my friend.
Stay still, honey.
Stay still. Can you open your eyes for me, my friend? Can you open your eyes? Can you open your eyes? Are you having any pain in your legs or your back? Yes or no? What's that? Where is your pain? Back or legs? Where? Are you having some leg pain? Can you
No.
open your eyes?
And we know he's going to have pain because we're right where his pain is coming from. And that's what we're trying to fix.
Hey honey, can you open your eyes?
Stop moving around. Lay still.
Are you having any pain?
At this point, we're going to put our second tube for the discogram. Some patients are a little wormy, like him. It's fine. It's just coming out of the sleep. It's normal to move. You all saw Aliens, right?
Stay still, honey.
All right. Everything will be done through this tiny 7mm incision. All right. What did you get, Berndes? Propofol, fentanyl, what else? No fentanyl yet?
He got a little bit of fentanyl in the bag. One
So,
person.
yeah.
But that was a long time ago. He should be waking up. Okay.
Alrighty. You okay?
Yeah?
Lay still. Stop moving.
You got that at 11:08.
Stay still, okay?
All right.
Are you having any pain? No?
Good. How bad is that on a scale of 1 to 10? How high does that go?
0 to 10, sir.
Give me a number.
8.
Is that where you normally get your back pain? Yes.
Good job. Thanks for the help. 8 over 10, and it's concordant. That's at L4-5. Is that better now?
Is your pain better, my friend?
Yes.
All right. Lay still. We're almost done. We're going to put you back to sleep in a minute. I just need you awake. How bad is that on a scale of 1 to 10? How high does that go?
10. Is that where you normally get your pain? Yes.
Yes.
All right. You get to go to sleep. When you wake up, you get to do your little dance, and then you get to go home. All right. At this point, we've tested the L4-5 and the L5-S1. You can see the tears in the back of the disc, Jordan. Henry, stay on the x-ray, and we'll show you these tears. One there. Jordan is giving me vertigo. One tear there at 4-5, another tear down below at 5-1. That's what we're targeting, the tear and the herniation. No, you're in. Let's see, shot. Don't push forward.
No, I'm putting out the needle.
You're fine. Just hold it still, and then pull the needle out. We're going to start at L5-S1. Any questions from the audience? Take your time.
Yes, we have 2 questions. This first one comes from
Get some more num-num.
this first one comes from someone else on YouTube,
Sure.
and they ask, "Is this his MRI?
I'm sorry, is this what?
His MRI, the one on the bottom right corner?"
Yeah. I believe it is.
Indeed so. Our next question comes from Bethany on Facebook, and they asked, "Are there any conditions that cannot be fixed with DLDR and can only be resolved with a fusion?"
Hi, Beth. Thanks for asking. No. There is one condition. Basically, it's spondylolisthesis grade 3 or grade 4, which is nobody has. I've never seen a patient with a grade 3. I think I've seen one patient in 28 years with a grade 4, 3 or 4. So most people have spondylolisthesis grade 1 or 2, and those can be fixed with the DLDR. The kind of things that DLDR fixes is disc problems. That's why it's called the Duke laser disc repair. We're actually getting rid of back pain coming from a herniated disc or bulging disc, slip disc, prolapse disc, protruded disc, ruptured disc, extruded disc. So 10 different names for the same thing. It's basically a tear in the back of the disc that causes back pain. And that's what we're fixing. Can you show the video to the audience on why does a disc problem, a disc injury, cause back pain? And let's show them that.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Yeah, we're in. All right, welcome back. We have just placed the endoscopic tube. You guys see the tube here? This looks like a metal straw. It's actually, the whole surgery is going to be done through this small little tube. That's why this is the most minimally invasive spine surgery that can be done for a disc problem. Somebody asked earlier about fusion. And the answer is fusion's totally unnecessary. Laminectomy is a horrible procedure. Discectomy is a horrible procedure. They all destroy your spine. If you've ever watched a laminectomy, the surgeons basically have to make a cut here. They go down and peel the muscle off your spine, damaging the muscle. They then drill holes in the bones in the back of your spine called a laminectomy or laminotomy. And all of that to get to the herniated disc. Well, we're going around the spine, so we're not damaging the spine. Why would you want to damage the spine when the spine is already damaged? You don't want to damage the back of the spine to get and fix something in the front of the spine. So Dr. Camden, orthopedic surgeon at Pittsburgh, found a way to go around the spine through the front. And the top spine surgeons in the world use this technique. You're not going to find it everywhere, though. Here it is. We're now inside the tear and disc. You see that? So we're going to go in and remove the herniation that's stuck in the tear. We're going to clean that tear out with a laser. And when we're done, his back pain will be gone. Now, people say to me, can this fix all back pain? The answer is no. This fixes back pain that comes from a herniated disc. And Carl is here, who's building our new website. And I've talked to Carl and Victoria many times about how there's so much confusion about disc injuries. Disc injuries are all the same. They're a tear followed by a herniation into the tear. And the problem is that there's 10 different names for the same thing. Herniation, bulge, protrusion, extrusion, rupture, slip disc, they all mean the same thing. It's all a tear with a herniation. There's no difference. And by the way, they all cause pain the same way, through inflammation, which you just saw. So the Duke laser disc repair fixes all of those problems with one simple surgery by cleaning the tear and allowing the disc to heal naturally, without metal, without fusion, without artificial disc. This is a piece of herniation right there. See the laser hitting it? And that's a scarred piece, because look at all the gold, look at the white, that's not normal. That means that this piece of herniation has been attacked by this patient's inflammatory system. Okay? The patient's body is attacking it. So let's show the video of how the Duke laser disc repair actually repairs a damaged disc.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. Now we are at the L5, can you lower your IV pole please? We're at the L4-S1 disc. That's better. And all of this is scarred up herniation. It's from chronic inflammation. Inflammation that your body is basically attacking a foreign body, which is the herniation. Shouldn't be there. And it's attacking it, causing back pain. You could see it. The amount of scar tissue is proportional to how long the problem has been there. Short-term disc herniations, like if you just herniate today, come in, it won't have scar tissue, it won't have the gold stuff. It'll just be a fresh herniation. It'll be very blue and soft. and the laser will zap it away quickly. But when you leave your herniation for years, look at that tear right there. See that? All that junk stuck in there? This should be closed. It should be white, not blue. It should be completely white and beautiful. That's what a normal annulus looks like. It's white, collagen. Doesn't have any gold, it doesn't have any blue, it doesn't have any scar tissue. It's just beautiful collagen, layer after layer, like an onion. 25 layers of collagen, holding the jelly in the center. Well, when you get a tear in that wall, or the collagen, the annulus, then the jelly squeezes out into the tear and causes back pain. That's what we're fixing. All right, any questions from our audience?
No current questions.
They know everything. Now, this patient traveled here from where?
Virginia.
That's right, Virginia. This patient came from Virginia, and I think he came with a good friend of his. So he'll be here 3 days, Wednesday, Thursday, Friday. That's all it takes to get your back fixed at Duke Spine is 3 days. And earlier I mentioned, does all back pain come from a herniated disc? The answer is no. It turns out that 85% of the time back pain is coming from 1 or 2 or 3 or more damaged discs, okay? And that around 15% of the time it's coming from something else. What is the something else? Well, the most common is the facet joints, spelled F-A-C-E-T, facet joints. They're the second most common cause of chronic back pain. And we see that all the time here at Duke Spine. There's a little bit of fat that got stuck in there as we pass through the foramen on our way down to the disc. Yeah, he's not liking this because this is the most painful part of the herniation right here. This is the part you cannot neglect. You have to get it. If you don't get this part, the patient will still have back pain. Now that laser fiber that you're seeing up there, the glass, is 1 millimeter wide. So that's how small the fiber is, 1 millimeter. Right, Luis?
Yes.
And this is the back of the herniation right here. The Duke Spine Institute is the first place in the world to do a debridement of the annular tear in the back of the annulus and to eliminate back pain, neck pain, thoracic pain. But of course, operating on someone's lower back isn't going to fix their neck pain, right? So people have herniated discs in their neck. They get them in their thoracic. They get them in their lumbar. Lumbar being the most common place for a symptomatic disc herniation. Unfortunately, most surgeons, they don't know how to do this kind of surgery, so they're going to recommend older types of surgery like fusions or artificial discs. It's really hard to get surgeons to change their recommendation because people are complacent. They just allow the surgeon to do what they want, which is to do fusions. And people need to start demanding from their surgeon, I don't want a fusion, I want endoscopic surgery, I want Duke laser disc repair. When you do that, what's going to happen eventually is the surgeons will have to change the surgery they offer their patients. And they're going to have to offer them better surgeries, like this endoscopic procedure. All right, I'm going to go in and grab out some of this herniation. You see the laser and the pituitary rongeur, this thing, they work together to remove the herniations. You really need both. You can't do the surgery without both of them. That's why I use both, every surgery. Okay? The grabber takes the big herniation pieces out, and the laser takes a lot of the smaller ones, which most of the time that's what you have. Plus the laser cleans the tear. Can't clean the tear without the laser. That's the tear, by the way. See how we've cleaned it all out? The laser does 95% of the work. Little piece of herniation there. Little vein right there. Now his herniation at 5'1" is a little more medial towards the midline. Very hard to get to. I never get all the herniation. It's not possible. Actually, the truth is no doctor gets all the herniation. There is no way to remove 100% of a herniation. I've never seen it done in all my years as a neurosurgeon, not by me or anybody else. So a lot of people are under the misunderstanding that surgery like this or any surgery on the disc is designed to make your disc look normal. Your disc will never look normal, ever again. There is no technology in 2023 or earlier that allows discs to go back to looking like they were before they were injured, okay? What we try to do as doctors is make them not hurt, make them asymptomatic. How's he doing? Huh? I think he's light, but that's okay. He's not doing anything bad. He's fine with me as long as he's okay with you. All right. So far, everything's going very well for this young man from Virginia. We have a lot of patients from Virginia. And, you know, I hate to say it, but the people from Virginia seem to be a little smarter than the rest of the people who are going out and getting fusions done, because they won't take it. They know there's something better out there, and they come and get it. They don't want fusion. And they're not going to just sit there and take it and get a fusion. All right, so I need to aim a little more medial. That's what I'm doing now.
We have a few questions.
All right. Yeah, I'll take the questions. It's fine.
This first one comes from someone else, once more on YouTube.
All right.
And they said, "No, we don't know everything, doctor. Thank you for all of this information. I want to ask if the tear is in the center of the disc, which side you choose to insert it."
Great question. Yeah, so the question was, Doc, if the tear's in the middle, how do you know which side to go to? That's a great question. So the first thing I do is I ask the patient, what side's worse, left or right? And I always go on the side that they feel worse. Remember, this is not as much a structural problem as it is an inflammatory problem, right? So the idea is, that's, by the way, this herniation right here I'm taking out right now is more from the middle of the disc. I'm reaching across to the middle, okay? Right through that little corridor there. And I'm pulling out pieces of that herniation. Lots of little pieces. They're cluttering up the view. So I start by asking the patient what side is worse, left or right, and I use that to guide me. And as long as they show me that it's worse on the left or right, and it's right where the herniation is, then I know that the herniation is more symptomatic on that side they're showing me, okay? So I'm going to be inclined to go to that side. The other thing I use is, where do you have leg symptoms? So if their leg symptoms are on the right leg, I'm going to go to the right side, because clearly the right side is worse, like more inflamed. So I use the side of leg symptoms. I use the side that the patient tells me is their back pain's worse. And I also use, on physical examination, I could find weakness in some people. I use that weakness side because that's the side that I need to get the pressure off the nerve, weakness or numbness. So I use the physical exam, neurological exam. I use the MRI report and the MRI itself. And I use the patient telling me which side is worse in their back and which side is worse in their leg. I use all that information to make a determination. And some people actually need both sides. We have to go on both sides, you know, to get enough of that herniation out. And so we'll tell them they need it on both sides. Great question. Almost done on this disc. I just keep pulling out little bits of herniation. I want to make sure I get it all. I don't want him to have to come back, or anyone to come back for that matter.
We have another question.
I'll take it.
This comes from Jonathan Pugh on YouTube. And they asked, what prevents the nucleus propulsus from continuing to ooze out after removal of herniation/scar tissue via laser?
Yeah, great question. You said Jonathan?
Correct.
Jonathan, great question. So look here at the nuclear material, right? That's not liquid, it's solid. And it will not come out of the hole unless it's under pressure. You actually have to push on it really hard to get it to squeeze out. So as long as the patient doesn't do heavy lifting or a lot of bending at the waist after surgery, it will not come out. And that's what we ask the patients to do. So a lot of the patient's proper recovery requires the patient to do what we ask them to do after surgery. We can only do so much. It's the same thing for all spine surgery. Even if you're doing a fusion. If you've ever had a spinal fusion, maybe you've heard your surgeon say to you, hey, you cannot use tobacco products, right? And you ask, well, why can't you use tobacco products? The answer is tobacco products will prevent fusions from happening. Like, nicotine will prevent fusions from happening. So if we tell our patients don't use nicotine, but they still use nicotine, obviously, I can't force them not to use nicotine. We just tell them. But if they don't listen and they do bad things, that's going to affect their recovery. Same thing with this surgery. All spine surgeries have restrictions and limitations the patient has to follow or adhere to. If they don't, that's a problem, okay? Now that's really interesting. We're almost seeing the edge of the next nerve going down, which is the S1 nerve root, right there. See that, guys? That thing right there by the veins is the edge of the nerve root, I believe. And you can see how it's protected so I don't hurt it using my tools. And this is typical in spine surgery. We retract or move aside nerves so that we can do surgery. That's what neurosurgeons do. We move things over, especially nerves. Now, we're the only doctors that should be moving nerves over to fix things. That's why we're neurosurgeons. We're trained to do surgery around the nerves. But unfortunately, there's other doctors who have been trying to do neurosurgery without the proper training. And the patients don't do well. They have a lot of complications. But as a neurosurgeon, we know where the nerves are and we know how to treat them properly. I'm just about done here. I just wanted to get as much of that central kind of herniation as possible. And I've done everything I can at this point. And I feel I've gotten 80% of his herniation out. And he should do really well. I like to use this as a reference number. We need to get about 50% of the herniation to get rid of the symptoms. Usually that's a rule of thumb, 50% of the herniation. But it has to be the right 50%, obviously. And you're never going to get 100. I told you that already. There's nobody that can get 100. No doctor in the world. And no surgery in the world that gets 100% of the herniation out. Okay? So the idea is to get out as much as you can, at least 50%. That way you get a good result clinically with the patient. Okay? Now, if it was a brain tumor, it would be different. We would need to get more. We'd want to get 100%. But even with brain tumors, we don't get 100% anymore. We get, 50, 60, 70, 80, 90. But brain tumors, what you're left with, you can do radiation on, and you can radiate it. Done.
Lights on, please. Thank you.
So we're not going to radiate the disc because it's not radiosensitive. In other words, disc herniations don't grow like a tumor. They're just a squish out. It's like the stuffing coming out of the mattress. They're not actually biologically active in terms of growth. They don't get bigger. They can herniate more, but they don't proliferate, which means that the cells in the tissue are growing and dividing like a tumor. Because it's not growing and dividing, you can't radiate it. Radiation won't work. So when there's residual disc, there's just residual disc. There's no adjuvant therapy like there is with a tumor or cancer, where you can do chemotherapy and radiation therapy to arrest the growth of the cells, because there is no cell growth. Anyway, just digressing a little. Do you have another question?
Yes,
Thanks.
we have a question from Anna on YouTube.
Hello, Anna, on YouTube.
And they ask, can running cause damage to this part of spine? I'm 54 and an avid runner and not doing as many half marathons this year because my back starts hurting. Then legs are in pain for days but never goes away.
Hi, Anna. Your problem is your herniated disc. We can fix it for you and get rid of it for the rest of your life with this exact procedure you're watching today. Your problem is you have a herniated disc or 2 or 3, and that is what's causing your back pain, the herniated disc. So if we were to go in and fix it, you would notice an immediate relief of your back pain, and it would be gone permanently, and then your nerves, which are getting pinched, causing your leg symptoms or inflamed, that would go away as well. Sometimes the nerves need a few weeks to completely heal after surgery, but the back pain from the disc is usually gone right away, immediately. There's been a few times where it doesn't go away immediately, and it takes a few weeks, but generally 99% of the time the back pain's gone immediately. So does running cause damage? No. What running is doing is you're loading your spine with weight every time you take a step. You're bouncing up and down. That's putting pressure on the disc that's already herniated. And what that's doing is it's causing the herniation to get worse. Hold up. Let go. Not yet. All right, let's put a little num-num. So we're going to go for the second disc now, which is the L4-5. Remember, the L4-5 had 8 out of 10 pain. The L5-S1 had 10 out of 10 pain. So I just gave a little more numbing medicine. And as I've said many times before, when I take the tube out, there can be some vein bleeding. You want to hold pressure on the muscle to stop any vein bleeding. Vein bleeding is not serious at all, but you don't want it to bleed, so you want to hold some pressure. All right, let's see what we've got. Looking good. Still a little bit of vein bleeding. Now, what increases your chances of bleeding in surgery? Well, there's certain things that do. And the most common by far is taking blood thinners before surgery. And a lot of people don't realize they're taking blood thinners because there's a lot of over-the-counter blood thinners like turmeric, aspirin, any kind of anti-inflammatory. Is that it right there?
Yes, sir.
Hold pressure here. All of those things are blood thinners. Shot? And more, like fish oil, for example. A lot of people don't realize fish oil actually causes bleeding because it blocks the function of platelets, which is necessary to stop bleeding. So there's all kinds of stuff. I'm sure drinking a Red Bull, okay, I don't want to get sued by Red Bull here, but I'm sure there's lots of stuff in Red Bull that could cause bleeding. So people just need to be aware of that and cautious before they have surgery, that there's a lot of herbal stuff that causes bleeding, okay? And we go over a list with our patients that we're aware of, but we don't know all the herbs out there that can cause bleeding. I got it. Okay? So I tell people get off these energy drinks before their surgery because those energy drinks have got a lot of weird herbs and stuff in them that are not really studied, and they're not FDA regulated. That's a problem too, the fact that they're not FDA regulated, because now you have no idea what's inside the energy drink. They don't tell you. It's their secret concoction. But that secret concoction can actually, that's fine. No, we're fine. The secret concoction can actually be really bad for you. I don't let my kids drink energy drinks. I personally think they're dangerous. Sorry. I hope I don't offend anyone, but all right, hold this. We're right here. This herniation, once again, is not a big one. That's why we're not going to be doing a whole lot at L4-5, but there was a tear, and it was definitely painful. Laser, you can see the tear right there. You guys see the blue crack? Whoops. Right there, you see the stuffing coming out? That is the annular tear. So. Now, a normal disc doesn't stain blue. It's white. So if this was normal, you wouldn't see any blue. It would just be white. See those fibers right there? Those are annular fibers. They're white. I have to release some of them to open up things a little bit to get enough of the nuclear material that's herniated out. See all this blue stuff here? Got to clean as much of this out as I can safely. Starting to feel a little bit of scar tissue with the laser fiber. I can feel it. You use the laser fiber like a finger. You know, surgeons use their surgical tools like fingers. You know, they're not just sticking them in. We actually feel with our tools. Even with robotic surgery, you can actually feel resistance. You can feel texture with the tools. That's how it's designed. It's designed to give feedback. All right, I need 5 minutes, doctor. 5 minutes. This is scarred right here, clearly damaged. It's perfect. I just need 5 minutes. We'll be done. There's the kind of the top of the tear right there. All right, questions?
Yes, we have 3 questions. This first one comes from Suvar on YouTube. And they asked, "Hi, doctor. My question is based on your knowledge, how likely it is for the disc to retract through decompression, negative pressure therapy. Do you believe that that is possible at all?"
Thank you for asking. I get this question a lot. People with a herniated disc, they ask me, can I do decompression therapy and make the disc go back in? The answer is no. You cannot, okay? Even if you did, do you want this damaged disc back inside? You don't, because that's only going to cause more inflammation down the road. You do not want that herniation back inside your disc. So the kind of doctor that tells patients this is a chiropractor. The chiropractors and physical therapists, because they make their living off of treating back pain, and they want patients to believe that their treatments will let the disc go back in. But it's a lie. It doesn't work. I've never seen it work. And that would be like saying putting a disease, something with disease on it, back in your body. Once that herniation happens, the day it happens, you start to get inflammation. And that inflammation damages that nuclear material. See the tear here? I'm cleaning the tear right there. You guys see that? Tear?
Yes, we do.
Yeah. So if I clean the blue stuff out, the white stuff, this nice healthy white annulus is going to close back over. It'll reconnect. Okay, it's going to take a year to fully reconnect, but it will reconnect. You guys see that? So this right here that I'm touching with the laser used to be connected over here, and now there's just a scarred up mess there. I got to clean as much of this blue and the scar tissue as I can, and that will let the disc now heal itself. This is the debridement, by the way, that we talk about, the annular debridement. This is what Duke Laser Disc Repair does. It does an annular debridement. It's the only surgery in the world that does. So to answer your question, no. The decompression therapies chiropractors do, they don't work. So patients will get better, but they get better because the inflammation is reduced on its own. Even if you don't go to the chiropractor, even if you don't get that therapy, you're going to feel better after a while because you're not as active and you're not creating pressure on the herniation, so you're not getting as much inflammation. Basically, you're just healing yourself, partially healing. But the problem is you'll never completely heal unless you have this surgery that cleans this material out. This material never goes away on its own, okay? We've believed for a long time it could, but it doesn't. And people are just susceptible to re-injury. 1 minute, we're just about done. And this patient is going to go to recovery. He'll spend 1 hour in our recovery room and then go home. Now, he lives in Virginia, so we'll see him back tomorrow, and then he can fly back to Virginia after I see him. Great question. Do we have any more?
Yes, we have 3 more. This next one comes from Jonathan, once more on YouTube. And they ask, is there any direct way to increase production of collagen types 1 and 2 to promote intervertebral disc healing / health?
Well, Jonathan, that's the $1,000,000 question. That's a great question. I don't know the answer. You're asking me a question I don't know the answer. So the question was, doctor, how can you get that annulus to heal faster with producing type 1, type 2 collagen and elastin, maybe even other types of collagen? Because there's so many types of collagen now. There's over 10 different types of collagen we've discovered. We used to think it was 1 and 2. Those are the most abundant. But there's so many types of collagen that we're discovering. Long story short, I don't know the answer. I don't know how to make this thing seal up any faster. People say, can I take hyaluronic acids or collagen? You can, but I don't know that that's going to come here and work. So do it at your own choice. But I'll be honest with you, the patients that have this surgery, they heal 99% of the time without re-herniating. Only 1% re-herniate. The nerve is in there, by the way. The nerve root is there. You see the red? That red is a vein on top of the nerve root, but it's buried in the fat, a lot of fat. Now look, as I come out, look how small the hole is, okay? Let's have the laser fiber. You guys see the size of the hole right there in the annulus? Now look, this laser fiber is 1 millimeter from side to side. So the hole is really only 2 millimeters by the time we're done, okay? So that should heal very quickly. All right, I'm going to come answer your questions face to face. So go ahead and type them up. In the meantime, we're going to put some antiseptic, betadine, to clean the wound so there's no infections. We've never had an infection. 16 years of doing this surgery and never had an infection. I used to get infections with my fusions, and that was not common, but I did get them. And I figured out a way to reduce the infections with fusions to 0. It requires several things, but other doctors have not been able to reduce their infection rate to 0, but we have at Duke Spine with fusions. And it's a lot of things. It's not one thing that does it, but having the best staff, having the best autoclaves in the world, which we use BellyMed, German, top of the line, best autoclaves, killing all bacteria and funguses. We have sterile technique that's awesome. We have antibiotics, the best. We have the best of everything. There's about 100 things we do during fusion to make sure that we don't get infections, reduce the chance. One of them, I put vancomycin powder in the wound bed after I'm done. And we're going to be doing a fusion, I think, next week on Tuesday, right? Yes. So we're going to do a fusion next Tuesday. And you're going to see firsthand how I do a lumbar fusion if you come and watch. And we're going to put, at the end of the surgery, you're going to see me put a powder. That's vancomycin powder. And the reason we chose vancomycin, you guys see the incision here?
Yes, we do.
The reason we use vancomycin is because it's the best antibiotic to kill MRSA, methicillin-resistant Staph aureus, and Staph epidermidis, which is, by the way, the most common bacteria that causes postoperative infections with spinal fusion. So I haven't had a spinal fusion infection in about 12 years. because we use the vancomycin topically, powder, as well as the IV antibiotics. And we use drains, and we have minimal blood loss, all that stuff. All right, EBL, I'm going to put as 2 mil. Doctor, we did a left DLDR, left L4-5, 5-S1. Everything went really well for this patient. Where's the rest of my papers? Yeah, you got to have those right for me.
I don't know what this is. I left it to
That goes to, it's a email to the patient. Okay. Good job, everyone. Thank you. Go ahead and type up your questions, folks, and I will answer them face to face. Don't forget about the Duke Spine Institute app. We have an app. It's free, and it's on iPhone, is Apple, as well as Android, and you can download it onto your computer. It's got a lot of useful information. Okay, I'll be there shortly to answer your questions. Type them up, please, and go ahead and run one of our testimonials. This is Dr. Ari Duke-Majan, CEO and founder of the Duke Spine Institute. I'm here with one of my patients, and you've traveled from where to the Duke Spine?
Idaho.
Idaho, with your lovely husband, and we've had a few conversations. She came here to have her back fixed. How long have you had back pain for?
For over 7 years.
Okay. And what kind of work did you do before you retired, if you don't mind me asking?
It was desk work.
All right. And so you had back pain for 7 years. Did you have an injury to your back, or did it just kind of gradually come on?
It just gradually came on. I actually noticed it first in 2015 when I was gardening and I couldn't be up there for 8 hours. I was into it for about 4 hours and I had to take a break. And as time progressed, my breaks got longer and longer, and the amount of work I did in the garden was less and less.
Understood. And you're retired now. So what's it like having back pain limit your ability to do stuff when you're retired?
For me, it's very frustrating. I can't do that what I want to do. So we kept seeking solutions and nothing was working. They did work for a short while, but that short while decreased over time. It was shorter and shorter. My husband does research very, very well. Through his research, he found you. We read that you can fix my back, and you did fix my back.
That's right.
And I thank you.
You're welcome. So when did you have the Duke laser disc repair done and the Duke plasma rhizotomy?
I had those done yesterday in the afternoon. I am sitting straighter than I have. I'm standing straighter. I'm walking normal. It's like, wow, new me.
Look at that smile right there. I hadn't seen that until just now. So
well, it wasn't there yesterday.
Yeah, it wasn't there before surgery. And how long have you been not smiling because you've been in pain? I mean, really bad pain. How long has the really bad pain been there?
Well, the really bad pain has probably been over the last 5 years. It's something that was really tough to maintain a positive attitude and try to keep a smile on my face and keep Jeff's hopes up. I tend to be a positive person, but there were times when it does drag you down.
Of course, yeah. It's hard living with chronic pain, and especially with loved ones, they have a hard time, relating. Of course, they want to be supportive, and your husband is a very supportive man, obviously. And he's a pleasure to meet. I know he's an author as well.
Yes.
And so what are you going to do now that you've had the surgery? And you could see actually the Duke laser disc repair procedure she had done yesterday. You can see right here, we went into the discs that were damaged. You had 2 annular tears. We tested your discs during the surgery, and indeed they were causing your pain. So we verified that with our discogram. And then I went ahead and used the laser to clean up the tears that were causing your pain and get rid of that source of pain for you. And here you are, you're doing fantastic. How much of your back pain from before surgery do you still have?
Oh, virtually nothing.
It's gone.
It's gone.
Cured.
My lower back, I have not been without pain in my lower back until your surgery. is constant, is always there. I've never been without it. I'm without it now.
So are you going to go back to gardening?
You bet I am.
All right, very good. And what other things would you like to do now that you have a new back that doesn't hurt you anymore?
You know, the biggest thing I want to do? I want to go fly a kite.
Good for you. Let's go fly a kite then.
That's right.
Well, congratulations on having faith
Oh,
and being
thank
brave
you.
and getting it done.
Oh, not a problem.
Is there anything else you want to say to your fans out there?
I highly recommend Dr. Duke's Spine Institute, Dr. Duke personally, to help you fix your back.
Thank you. Appreciate that. All right. Safe travels.
Phew, that wasn't too bad, was it?
It was wonderful. All right. So now you've had the surgery. How are you doing today?
I feel awesome. I mean, the only pain is, surgery site pain, and that's
Okay.
it. No nerve pain.
So the pain that you had before the surgery is
Gone.
gone, cured.
Gone. Yeah.
Awesome.
Yes, that's amazing.
I'm Dr. R. Duke Majan with the Duke Spine Institute, and I'm here with one of my patients who just had the Duke laser disc repair on her lower back, and she wants to share her story with you. Now, you came to Duke Spine Institute because you were having back and left leg pain for how long?
Well, the terrible left leg pain, probably about 2 years, but prior, I've had issues since I was 14 years old. So it's been a lot of roller coaster pain since then.
So you've had back pain since you were 14. You're clearly not 14 anymore.
No.
And so that's like 15, 20 years, right?
Yeah, too long.
And so why didn't you get it fixed sooner?
Well, the doctors when I was younger didn't want to operate. They wanted to, I was young. They didn't want to take a chance because all the surgeries then at that point, there was just nothing there that wasn't going to be traumatic to my back and my spine. So I went through physical therapy, shots, decompression. They did that and nothing was really working. And then it eventually kind of got better, and then it would get worse and it would get better, and it was just up and down, up and down.
Up and down. And the reason it got better was the inflammation from the injury to your disc started to get better.
Yeah.
But then you'd have another herniation with activity, and then it made it worse. So
Yeah.
when we were in there, and you can see from this video, I'm sorry to have to end the testimonial there, but we want to get to your questions, and we've just completed the Duke laser disc repair, which is an endoscopic, you all saw the endoscope, transforaminal. What does transforaminal mean? All right, you guys see the spine here? You guys see this hole on the side? There's one on the right side of the spine, there's one on the left. Those are called foramen. Foramen, it means an opening or passage in Latin. So transforaminal is a new type of technology that lets the surgeon go from the side of the spine through the hole that's already there. What's the advantage? Well, all the spine surgeons today in 2023 and for the last 100 years, they all go what's called translaminar. They have to go this way by the side of the spine, they hit the bone and they go, oh crap, how do we get down there to the disc, which is up here by the way, or here if you want to look at the herniation. So to get there, they have to start taking your bones and ligaments out of the back of your spine. Well, a very smart orthopedic surgeon said, we don't want to do that because that's going to destabilize the spine. So let's go transforaminal from the side. So he developed the technology to go that way, Dr. Parvis Kambin, and he taught a few people, some Koreans, some Chinese, some Americans. Anyway, I learned from all of them. They were the first generation, I was the second generation. And we basically come from the side so we don't have to remove any bones and ligaments or muscle. Prevents damage to those structures, and it lets us get straight into the herniation through a transforaminal approach. That's what we did today. We did it at L4-S1, which happens to be the hardest disc to get to in the lumbar spine, and most endoscopic spine surgeons, there's not many of us in the world, but the other ones won't do it, transforaminal, because it's so hard. At Duke Spine, we've been doing it 16 years. We do it all the time. We have no problem going transforaminal at L4-S1. And we did that for this gentleman. We also did L4-5, which is very easy to get to. So, surgery went well. We found that the L4-5 disc was causing around 50% of his pain, and the L5-S1 was causing the other 50%. He needed both discs fixed. He got both discs fixed. The L5-S1 took more time. It was more work because it was more damaged. The L4-5 was far less damaged, and we got it done quickly. Now, I get a lot of questions from people, well, you're inside that disc, aren't you damaging it? No, we're not. We're going through the tear that's already there. We're not creating a new tear. We're going through the existing tear and the existing herniation. So we did that at both discs, and when we came out, as we're coming out with the tube, we're using the laser to clean up the tear. Everything went well. This patient won't have back pain from his discs anymore. I already checked him for other causes of back pain like facets, and he didn't have any facet pain before surgery, no piriformis. So I think he's going to do fantastic with this surgery. We'll see tomorrow when he does his testimonial. First question.
First question comes from Miran on Facebook, and they said, what are your views on doing Duke spine repair surgery coupled with stem cell therapy? So removing the old broken furniture and allowing for some new tissue to develop in its place to better support the structure of degenerative disc.
Yeah, and I'm glad Carl's here to hear, because we get this question a lot. What about using stem cells with the surgery? We've tried it, and the stem cells cause horrible, horrible, horrible pain and inflammation. So we decided not to do it ever again. Stem cells are pro-inflammatory. They cause inflammation. So why would anybody use stem cells? The answer is because you need inflammation to heal. The problem is stem cells cause a lot of inflammation. Now, could we use a smaller amount, maybe a tinier piece of stem cells? Absolutely. But you know what? These people do so well without stem cells that doing stem cell therapy with the surgery, in my opinion, at this time, with our technology that we have, would just be unnecessary and increase the likelihood of complications. We've never had a complication on the surgery with Duke laser disc repair. We don't want to start having complications. There's an old saying, if it ain't broke, don't fix it. Next.
Next question comes from Doug Dean on YouTube. And their question is, what is the trick to getting your surgery covered by insurance?
So what is the trick to getting this surgery covered by insurance? We do get this surgery covered by insurance, Doug. It's covered by a lot of insurances. It's just not covered by all insurances. Doug, maybe you need a little bit of a lesson in insurance. Insurance companies make money by not paying claims. I don't know if you understand what that means. What it means is, if you've ever had anything broken in your house, let's say your roof starts leaking, you call the insurance company and you have coverage for a roof repair. The first thing they're going to do is try to not to pay for your roof repair. And the way they do that is they write a contract that has what are called loopholes. Loopholes give the insurance company an out, meaning they could point to one of those conditions in the contract and say, oh look, you're not covered because it was a thunderstorm, and we don't cover roof repairs that leak from thunderstorms. This is standard insurance stuff. Well, they do it for health insurance as well. And you've heard of it in the news. Oh, Obama wrote a law that doesn't allow insurance companies to deny treatment or payment for pre-existing conditions, right? Remember that? Well, that was actually a good thing Obama did. He basically stopped the insurance companies from using a loophole in their policies where they wouldn't pay for anything pre-existing, right? So for example, you would end up having a brain tumor. It needs brain surgery. And your insurance would say, sorry, it's pre-existing. We're not paying for it. Well, brain surgery costs about $100,000. So when you don't get that covered by your insurance, you're fucked. I mean, you're fucked big time. Because now you got to pay $100,000 to take a brain tumor out, right? But they don't care. The insurance companies don't give a damn about you. Therefore, the way you get insurance companies to start covering things is by talking to your politicians. Because the politicians wrote the laws that let the insurance companies not pay for your care. It's at a state level and at a federal level. Federally, for ERISA, covered plans, which are employer plans, and state level for all the state products, which is what most people have if you're not working for a company. So what you guys need to do to get insurance to cover it is you need to have a talk with your politicians and remind them who they work for. They work for you. So they should be writing laws that force the insurance companies to cover medical care that you need. So let's talk for a moment. What is the number one reason people declare bankruptcy in America? Henry?
The number one declare bankruptcy, some unemployment?
Nope.
No.
Unpaid medical bills. The number one reason Americans are declaring bankruptcy, and this has been for the last 15 years, is that their medical bills haven't been paid by the insurance company, so the hospital comes after them and they can't pay them, so they declare bankruptcy. Okay? Why is this happening? Why is unpaid medical bills the number one reason Americans are declaring bankruptcy? Because the insurance companies aren't paying. Has nothing to do with my procedure, my friend. Has everything to do with insurance companies being bad and not being held accountable. So, you want to fix the insurance problem? I strongly recommend you do that. But you have to do that, not me. I cannot fix your insurance problem. So, to summarize, many insurance companies pay for the Duke laser disc repair. Those that don't, we intend to pursue them and challenge them in court to get them to pay. And for those that do, kudos to them. But there will be a day, someday, we believe, where the insurance companies will be forced to cover this procedure, whether or not they like it. And we need your help to make that happen.
Last but not least, we have someone else once more on YouTube, and they said, with no insurance, what's the cost of surgery?
So we have somebody saying, I don't have insurance, or we don't have insurance. What is the cost of the surgery? The answer is, I cannot tell you because I don't know what surgery you need. It's that simple. Every surgery we do has a different cost. And the reason is everybody has a different problem. So if we're fixing one disc or two discs, are we fixing it one side or both sides? We don't know. The only way to know what your cost of your surgery will be is to do what's called a consultation. We offer a consultation virtually, which means anybody on the internet can get on their computer or iPhone and do a virtual consultation with me. At the end of that consultation, you'll know exactly what I'm recommending and you will know the price. I mean, not at the end of the consultation, the price, but I have to send it over to the surgery center. They price it out based on your insurance and stuff, copay, deductible, and you're going to get a price usually within a couple of days. So that's how we do it. There's no other way to do it. We need to know exactly what you need done. Now, you cannot come and tell us what you need done because I won't do the surgery when patients tell me what to do. This is not McDonald's. It's not drive-through ordering a cheeseburger and a fillet of fish and a shake. I have to be the one to figure out what you need. And the only way I'm going to do that is by seeing you, seeing your MRI at the same time. If I can do that, I can tell you what's wrong. I can tell you what needs to be done to fix it. Am I perfect in my diagnosis? No, absolutely not. Do I miss things? Sure, but it's rare. I'm pretty darn good at diagnosing spine problems over the internet. Okay, so we use Zoom. We look at your MRI that you send us, and I look at your questions and answers that we give you. And based on that, my interview and my physical exam virtually, I can actually figure out what's wrong, about 98% accuracy. Okay, so the people that come here, we give them a recommended treatment. They pay for it in advance. They show up, they get their surgery done, and I'm able to get rid of their pain almost about 98% of the time. I can cure their pain. Now, sometimes people have another source of pain that crops up later on, like their piriformis or their facets, which we didn't treat. They're going to need treatment for that. That's a separate problem. Okay? But generally, the virtual consultations we do are really, really good. I strongly recommend, if you're thinking about it, get it done. We usually offer them for free, but sometimes people have to pay for a consultation, but I think it's $99. It's dirt cheap, okay, for seeing a neurosurgeon and getting a diagnosis. Any more questions?
Yes, we have one more question from someone else once again, and they said, you said 1 millimeter hole in disc, it will heal in about a year. So 1 year, what I have to do and not to do for not to be herniating again?
All right, great question from one of our viewers who's saying, hey, you said a 1 millimeter hole in the disc that needs to heal, it takes a year. Okay, just to be clear, the last hole that I just showed you here was 2 millimeters. The point is everybody's annular tear hole is different sizes. The average is probably going to be around 5 millimeters. In this last disc I did, the L4-5, it was 2 millimeters. So the L5-S1, it was around 5 millimeters. Everybody's hole in their disc is different size when I get done. But the range is probably 1 millimeter to 6 millimeters, and it takes about a year for that disc to heal. So what do you have to do? You don't have to do anything your first year except eat regular food, take some vitamin C is what I recommend, maybe take some collagen pills. But what you really have to do is avoid bending at the waist, picking things up from the ground for the first 3 months. So no bending at the waist, 3 months. You want to avoid lifting heavy items your first year. So you have a 40 pound lifting restriction. So don't lift over 40 pounds your first year. Don't bend at the waist. Avoid contact sports like football, wrestling, other types of things like that. Why? Because they put a lot of pressure on your discs. If you're doing contact sports, you're putting pressure on your lower back down, and it could push out some more herniation. We don't want that happening in the first year while your disc mends.
And that is it.
All right, I hope you enjoyed the surgery. We'll be back. Our next surgery is a 1-level L2-3 right-sided Duke laser disc repair. This patient has a fusion done in his back from L2 to L5, done elsewhere, not by me, and he developed what's called adjacent segment disease. So the disc below the fusion and the disc above the fusion now have problems. We fixed the one below, now he's back for the one above. So it's going to be a right L2-3 Duke laser disc repair for a herniated disc, pinching the L2 nerve root in the foramen, which is causing pain in the front of his thigh on the right side. So we're going to help him with that. Our last surgery of the day is going to be a doozy. That patient is from, I want to say, North Carolina. Yeah,
Sure.
that patient is from North Carolina. And we're going to be doing a left L4-5, L5-S1 Duke laser disc repair. And we're going to be doing the Duke plasma rhizotomy for facet pain on the lumbar, thoracic, and cervical. We won't be showing the plasma rhizotomies yet, but we will stream the Duke laser disc repair in the beginning. Hope you enjoyed the surgery. Any more questions?
No more questions.
Check out our app, the Duke Spine Institute app. It's free. We don't charge for it. And if you know somebody who's got back or neck problems, have them upload their MRI and do a virtual consultation.
Just gonna send the app
Well,
link.
Yeah, we'll put a link to the app in the dialog box, and thanks for joining us. I've enjoyed it. We'll see you back shortly for our next surgery.